Good morning, everybody. I'm Adelle. I'm a fourth-year resident from Walter Reed, and today I'll be presenting early hemorrhage control with next-generation topical hemostatic agents in a swine junctional hemorrhage model. This one. I have no financial disclosures with the presented material in this presentation, and all the views are my own. During this talk, I will briefly review the background and purpose of our study, describe our study design, discuss the results to include difference in efficacy between hemostatic agents, demonstrate the ease of use and ability to maintain hemostasis despite user experience level, and briefly discuss further ongoing studies in our lab. The majority of preventable deaths after combat-related injury that occur in a pre-hospital environment are secondary to hemorrhage. The mortality rate of casualties during the wars in Afghanistan and in Iraq who died before reaching an MTF was reported to be as high as 87 to 100%, with 91% of these potentially preventable deaths secondary to hemorrhage, and only 32% of them categorized as able to be controlled by a tourniquet. Given the difficult challenge in managing junctional hemorrhage injury pattern in which standard tourniquet may not be adequate, we have seen over the years an increase in commercially available novel hemostatic agents. The most widely used hemostatic agent in the military setting has been quick clot combat gauze, and this is actually the recommended dressing in the Tactical Combat Casualty Care Guidelines. As mentioned, there are several commercially available hemostatic agents on the market. However, there's a limited number of head-to-head comparisons of each agent under the same models of physiological stress. Furthermore, there exists a wide range of medical knowledge and capabilities under which these dressings are applied in combat scenarios. So the basis of this work, it stems from a previous work in our lab in which our previous collaborators identified 7 different hemostatic agents that were compared against the control combat gauze in a coagulopathic swine model of junctional hemorrhage. During the testing, the majority of these agents all performed with similar efficacy across all parameters. Our study design was modeled after this, in which we took 30 Yorkshire swine that were equally randomized to 5 different groups with 6 animals in each group: combat gauze, chitosan, Celox Rapid, Everest Patch, and XStat 30, all pictured below. And they were further broken down into 3 novice and 3 pro for each group for application of the hemostatic agents. The experience level was defined as if you were a novice, if you had less than 5 applications ever of applying any hemostatic agent, and pro is greater than 10 application of any hemostatic agent. Additionally, each of the different hemostatic agents affect the coagulation pathway in a different manner. Our protocol kind of went as such. We got access to bilateral carotids in the external jugular vein for hemodynamic monitoring, maintenance fluids, and pressors to be administered. We then did a groin cut down to expose the femoral artery. Before initiating injury, we did a 50% hemodilution or exchange transfusion in which 50% of the pig's blood volume was removed and then replaced with equal amounts of saline. And this was to induce models of acidosis and coagulopathy that we've previously demonstrated. We then got proximal and distal control of the femoral artery and created a 4 to 5 millimeter arteriotomy using an aortic punch. And then we allowed for a 30-second free bleed, which was to simulate injury in pre-hospital setting that would require immediate intervention in a place where surgical capabilities are not necessarily immediately available. We then applied the hemostatic agent according to the manufacturer's instructions, allowing for a total of 3 applications of the agent prior to entering an ICU phase, and we limited this number of applications to simulate the pre-hospital military setting in which resources are limited. Following the application of the hemostatic agent, we monitored the animals for 5 minutes to assess for rebleeding saturation of gauze before they entered the ICU period. And then they were in an ICU for about 60 minutes where they could receive pressors. And at completion, if they survived through the ICU, we did completion angiography to assess for distal perfusion, extravasation, occlusion, and then performed a movement test in which we ranged the limb several times to assess for clot stability. The device failed if we noticed that there was pooling on the gauze, pooling in the wound, if the gauze was saturated, or if the animal expired during the ICU phase, or if it required more than 3 applications of the agent. Based on our previous studies, the 50% hemodilution was a model for the lethal triad and induced coagulopathy and acidosis, as demonstrated by pre-intervention lab parameters and road temp data, which are outside published normal reference ranges for swine. Group comparisons were completed, and as you can see above in the graph and in the table format, there was no difference in the number of gauze applications required to obtain hemostasis between a novice and a pro applicator, except for chitosam, for which the novice group required a mean of 2.3 applications. Additionally, there was no difference in failure rate among the devices, 0% with the combat gauze, ranging anywhere between 0% and 33%, or failure rate by user experience that we noticed. Additionally, there was no difference in total blood loss following intervention, overall survival, or angiographic perfusion. In surviving animals, there was no difference in extravasation or perfusion that was demonstrated on angiogram. However, distal occlusion occurred more frequently in the combat gauze group, in which 5 of the animals that we performed angiography on all had distal occlusion in the combat gauze group. However, this difference was not significant. Here are some representative angiographic images, combat gauze, screen left, with demonstrating the profunda and then the femoral artery there with distal obstruction, and then Everest patch on the right, which is traditionally what we saw was Everest patch obtained hemostasis, however, allowed for distal perfusion. And then XStat 30, those little peanuts, obstruction, and the very rare chance that we saw extravasation. So in conclusion, in this model of uncontrolled junctional hemorrhage, the 5 hemostatic agents tested performed with similar efficacy. There was no difference in ability to attain hemostasis, device failure, or survival was demonstrated across experience level. And all of these tested dressings show promise for early hemorrhage control in the pre-hospital setting, which we have previously demonstrated. Currently in our lab, we are undergoing a second phase of this study in which we are evaluating the ability of these agents to control and maintain hemostasis in an open liver lac model. We're also comparing novice and pro applicators in the event that this happened downrange and somebody with minimal experience level would need to do this. Continued work in the ease of use and further investigations, including cost analysis, would be necessary to delineate to make recommendations for the ideal hemostatic agent in the pre-hospital combat setting.